Hi everyone. Sorry we're running a couple of minutes late. We were just getting everything set up. We'll just wait maybe a minute or so for some other people to join. And we will make a start very, very soon. We're not going to wait too long. We are here though. Okay. Just going to wait for a couple more people to join. Okay, so we'll make a start. Hello everyone, thank you for joining us today. My name is Gabby and I'm the education lead at SUPTA. This week we're focusing on neurosurgery, specifically the spine, and we're really excited to have you all with us. Today I am joined by Thomas, who is going to guide you through the spine. And he is a fifth-year medical student studying at Cambridge. To make the session as engaging as possible, we will be releasing polls at the end. These are completely anonymous, so we encourage you to participate actively. And if you have any questions in the session, please put them in the chat and we'll do our best to address them. At the end of the session, we're going to share a feedback form. If you complete this, you'll receive a certificate of attendance and exclusive discount codes for Teach Me Surgery, pass the MRCS. Additionally, the session is being recorded. The recording and slides will be shared on our medal page in a couple of hours after the session, so please keep an eye out for that. We're also excited to share that an exclusive question bank and other resources will be available from our learning portal, so please check them out on our website. If you create a free membership account with us, you'll automatically receive a discount code for 10% off Geeky Medics anatomy flashcards, surgery flashcards, and a knowledge bundle. We also have an exciting opportunity to all our attendees. 2 lucky people will win free access to the Geeky Medics surgical flashcards and Geeky Medics OSCE stations. To enter, please complete the Google form at the end of the session and enter the unique code that we'll provide. The more sessions you attend, the higher your chances of winning, so please stay until the end to get access to that. Finally, before we begin, we'd like to thank our partners, the Royal College of Surgeons of England, Geeky Medics, the MDU, More Than Skin Deep, Medal, Teach Me Surgery, and Pass the MRCS. So without further ado, I'll hand things over to Thomas.
Perfect. Thank you so much. Can everyone hear me okay? I think.
Yeah, we can hear you.
Perfect. So yeah, as I said, we're going to be touching on the spine today, and we're going to sort of be covering the sort of key acute conditions that we see with the spine, and sort of going over the management, the investigations, and the red flags you'd expect to see. So as I said, they'll be sort of putting some stuff out, some questions out as we're going along as well. So if you feel free to respond in the chat as we're going. But yeah, thank you so much for joining, spending your Tuesday evening on a quick review of the spine. So as we said, thank you to the several partners that sort of help these sessions run. And we've mentioned them before, so I won't go over them again, but there they are, all there. So today we're covering the spine, and we're going to go over several things. So we're going to quickly go over the anatomy of the spine so everyone can have a recap on the general structure of the spine, and then also the individual vertebrae. And then we're going to go over cauda equina syndrome, spinal cord compression, spinal infections, and then spinal stenosis. So the structure of the spine, overview of the human vertebral column. So as we know, the spine is very key for providing support, flexibility, and protection for the spinal cord. And very basic sort of structure is that it's composed of 33 vertebrae, and this is categorized into 5 key regions. So the regions of the spine, so we have the cervical spine, which is 7 vertebrae, the thoracic spine, which is 12 vertebrae, the lumbar spine, which is 5 vertebrae, and the sacral and coccyx. So the sacral spine being 5 fused vertebrae, and the coccyx being of 4. And on the right, we can see the different functions of each of these regions, which I imagine most of you guys will be familiar with, but essentially, yeah, supporting the head, allowing movement, and then connecting the rib cage for stability. The lumbar spine is key for sort of weight bearing and providing that flexibility. The sacral spine is there to connect the spine to the pelvis, and then the coccyx, also known as the tailbone, is sort of there for balance reasons. So the vertebral structure, so each vertebra consists of a vertebral body, which is for weight bearing, and then a vertebral arch, which sort of allows protection of the spinal cord itself. And then with each of those, there's a spinous and transverse process, and these are the key attachment points for muscles and ligaments. Intervertebral discs can be found between the vertebrae, and these essentially act as key cushions, and these are composed of sort of 2 key components. So you have the annulus fibrosus, which is a tough outer layer, and then you have the nucleus pulposus, which is the gel-like center, which is key for shock absorption. And then regarding the overall structure, if we're looking at it from a sort of very broad point of view, we have several curves. So we have the cervical and lumbar lordosis, which are the inward curves, and then we have the thoracic and sacral outward curves. And these are, again, key with the general functions of the spine, which is balance, posture, and shock absorption. So spinal cords and nerves. So the spinal cord runs through the vertebral canal and transmits signals between the brain and body. And there are several nerve root exits between the vertebrae. And these are, as you guys will know, help control movement and sensation. What can go wrong with the general spine structure? So I'm sure a condition you guys heard of before, scoliosis. This is the abnormal sideways curvature that we see sometimes. The discs between the vertebrae can become herniated and can even rupture. We can also get osteoarthritis of the discs and the bones, of the vertebrae and the discs themselves. And then we also get spinal stenosis, which is that narrowing of the spinal canal. But today we're going to be focusing on sort of the acute sort of conditions that we see with the spine and what can go wrong with that structure we've discussed. So this is just another summary, but essentially the spine is essential for movement, support, and protection of the nervous system. Proper posture, exercise, and medical care is needed to maintain spine health. Perfect. So starting with our first condition, cauda equina syndrome. So surgical emergency. I'm sure most of you guys would have heard of this before, and it's always mentioned on wards, but can anyone in the chat at all give me a description of what they know about cauda equina syndrome already at this stage? Either that might be the symptoms that we see, the urgency of the condition. Any ideas? So I've just seen one person having a technical issue there. But yeah, perfect. So as we know, cauda equina is a surgical emergency which is caused by the compression of the cauda equina itself. If untreated, it can lead to very severe complications. So paralysis is sort of the key one there. The peak onset is 40 to 50 years of age, and approximately this occurs in 4 in 10,000 patients with lower back pain. So although it sort of doesn't happen in that many people with lower back pain, as we all know, when we're on the wards, we're always looking out for this when anyone comes in with back pain problems. So what is the cauda equina itself? So it's a bundle of nerves located just below the spinal cord, and is formed by the nerve roots from L1 to S5. It has several functions, including sensory and motor impulses to the lower limbs, has motor innervation to the anal sphincters, and also parasympathetic control of the bladder, all of which are sort of related to the symptoms we see when the compression occurs. So cauda equina syndrome is compression of the cauda equina, and this can be due to several reasons. So disc herniation, which normally occurs at L5 to S1 or L4 to L5. Trauma itself, so that can be fractures or dislocations. Neoplasms, so these can be primary or metastatic tumors. Infections, so discitis or Pott's disease, and Pott's disease is just tuberculosis of the spine there. Chronic spinal inflammation, so ankylosing spondylitis, or things that we've done. So this might be from anesthesia complications or certain medications. So what are the red flag symptoms? So as you guys will know, when you're taking a back history, there are certain things we have to look out for. So lower limb sensory loss, which is bilateral, is a key symptom to look out for. Any sort of problems with bowel and bladder dysfunction are also red flags here. Lower limb motor weakness is an important red flag. So if there's sort of lack of power when you're doing your examination, things like this. If the back pain is really severe, this is always a red flag. And then also sexual dysfunction. So if the patients complain of sexual dysfunction in history, then this is also an important red flag. When we're doing our examinations, there are several things that we expect to find with caudal equina syndrome. So the first one being sort of anesthesia of the saddle region, which is just a perianal sensory loss. Although this is very specific, and any kind of sensory loss to the lower regions would be a red flag in this case. Loss of anal tone, urinary retention, and then hyperreflexia and lower limb weakness are also key examination findings. So the classification of caudal equina syndrome, so we can sort of put it into 3 categories. So we can get caudal equina syndrome with retention, which is where we have full urinary retention, motor and sensory loss. Incomplete caudal equina syndrome, which is where we have partial bladder dysfunction. So this might be a weak stream or a loss of urge. And then we have suspected caudal equina syndrome, which is, I guess, early stages. So sort of we have the back pain, we have leg symptoms with potential sphincter involvement, but there's been no sort of definite diagnosis of yet. Differential diagnosis for this. So this might be radiculopathy, so sort of just general nerve involvement, but this will show with no bladder or bowel dysfunction. Spinal cord compression, which will be sort of upper motor neuron signs only, and then just general MSK pain, which is usually what we see in back pain, but we always have to rule out these conditions that we're discussing today. So what is the investigation of choice? So we're dealing with the spine, so it can be no surprise that we're sort of looking at emergency MRIs for this, and this will confirm the compression, but also help identify the cause. The management, as I said, again, we're dealing with surgical cases here, so this will be sort of a rapid neurosurgical review for decompression of the spine, and the surgery must be sort of performed as soon as possible. And alternate treatments, if surgery is unstable, would be radiotherapy for malignancy, and then also chemotherapy if indicated. But yeah, the rapid neurosurgical review is sort of what we're looking for. Prognosis, again, it's really important to pick up as early as possible because prognosis is very dependent on time. So time from symptom onset to surgery, and then also depending on the underlying cause. But essentially early surgery leads to much better long-term bladder outcomes. So caudal equina syndrome, I'm sure you guys have all come across it before, but the key takeaway is it's a surgical emergency. You're going to see lower motor neuron signs and symptoms, which will be you're also going to see sort of bilateral symptoms, and then also the numbness that we mentioned in the red flag section. An urgent MRI is going to be needed, and early neurosurgical intervention is key for better outcomes. Perfect. So now moving on to our second sort of condition that we're speeding through is spinal infections. So as it's an infection, it can be caused by sort of bacteria, fungi, or viruses. And multiple spinal structures can be affected. So we see a spectrum of diseases and also a spectrum of presentations. But it's always good to think of spinal infections as a differential, whether that's in an OSCE, just to sort of have it in the back of your mind, or to sort of make sure you rule it out if you're thinking of an MSK cause and you've ruled out some of the other key causes before. Who gets sort of spinal infections? So and where? So it most commonly affects the lumbar spine, and then after this, the thoracic spine. And the most common types are sort of vertebral osteomyelitis, so infection of the actual bone and the vertebral body. Discitis, which is the infection of the intervertebral disc. Epidural abscess, which is between the dura mater and vertebral column. Subdural abscess, which is sort of key to identify because of the rapid spread that we see, as there's a lack of barriers in that subdural space. And then just sort of spinal cord abscess itself, which is within the spinal cord tissue, but again, this is very rare. So the pathophysiology of spinal infections, there's 3 main routes that we want to think about. So has it spread through the blood? And this is usually through the anterior spinal artery. Is the spread of infection direct? So this might be post-surgery, trauma, or spinal procedures. Is it been adjacent spread? So this might be from affected nearby tissue. And then the most common causes we see are going to be Staph aureus, and then also E. coli. And less commonly, we see fungal or tuberculosis infections, but it's always key to to keep those in mind. The risk factors are sort of what we expect from any sort of infective condition or picture. So we have IV drug use, which will be, again, that's spread through blood, immunosuppression, which for obvious reasons makes us more susceptible to sort of immune attack, diabetes, which again makes us more susceptible to sort of sort of conditions, especially if we're sort of in high states of hypoglycemia for long periods of time. Recent spinal surgery and a history would also be sort of a red flag for a risk in spinal infections. And then finally, malignancy, and especially if we get cancer-related immunosuppression, especially through certain treatments. So the clinical features, this would be severe back pain, so probably more than what we'd expect from an MSK, although this can be difficult to sort of take from a patient history. It's always important to sort of think about spinal infections. And then the other thing is just general spinal infection sort of signs, so fever, chills, and that sort of thing that we expect with any kind of fever and infection presentation. And then we also might see some neurological deficits as well. And then spinal tenderness on examination. So if we're touching the spine and that's making the pain worse, then that's an important differential for us. Regarding the lab tests, we'd want to do full blood count, CRP, using these LFTs, clotting studies, as well as blood cultures. And then with imaging, again, we're dealing with the spine. So MRI with contrast would be the gold standard. And then also a CT scan, which will allow us to detect bony involvement. And then also a CT guided biopsy, which we need for microbiology and histology to sort of target our treatments effectively. So what is the management of spinal infections? So be no surprise when we're dealing with infection, long-term IV antibiotics, and yeah, his hospitalization will be required for this. And it's important to immobilize the patient if they're in significant pain or if there's any instability with the spine. When do we turn to surgery? So if there's spinal instability, so we're seeing bone destruction, if we see any sort of neurological deficits due to the risk of sort of cord compression, and then any sort of failures of conservative treatment. But there's a very simple aim. It's eradicate the infection, preserve neurological function, and restore spinal stability. Perfect. So moving on to the next one. Sorry, this is a bit of a whistle-stop tour, and me doing a lot of speaking. Oh, sorry, I've just seen on the chat. We have a few questions. So I'm sorry. Yeah, I'm sorry about the technical difficulty for that. But yeah, there will be a recording. So hopefully you can go back and have a look at that. So sorry about that. But yeah. Perfect. So just to continue, so we have the acute spinal cord compression. So this is a neurological emergency which will require immediate intervention. And then again, as with all these spinal sort of cases we're dealing with here, it's that key prognostic factor being the time from diagnosis to treatment. So it's always important to identify as soon as we can. And the most common cause in spinal cord compression is that metastatic spinal cord compression. So the various causes of acute spinal cord compression. So we have neoplastic causes. So as I said, these are metastatic spinal cancers. And these normally come from lung, the breast, prostate, renal, and thyroid cancers. We have traumatic, sort of trauma-causing acute spinal cord compressions. This might be vertebral fractures or facet dislocations. We have infective causes, so epidural abscesses, tuberculosis, fungal infections, and sort of any other sort of infective cause we can see there. So linking back to what we just discussed, infections of the spinal cord can cause spinal cord compression, so it's an important thing to look out for. Disc prolapse, which is a rare cause, and again, this mostly affects cord equina instead, but it's an important one to think about. And then any kind of degenerative or inflammatory conditions that might cause that spine to be compressed, so spinal stenosis, ankylosing spondylitis, or rheumatoid arthritis. So the clinical features of acute spinal cord compression, we get back pain, which will usually be worse with coughing or sneezing. We get dermatological sensory loss, which is below the lesion level. We then get weakness, and this can be bilateral or unilateral. And then the key sort of clinical feature of acute spinal cord compression is upper motor neuron signs. So when we're dealing with the upper motor neuron, we can sort of imagine that that's supposed to be controlling all of our other nerves. And so if we get the hyperreflexia, the spasticity, Babinski sign, and clonus, then we're thinking, okay, these nerves, these motor neurons, lower motor neurons aren't being controlled, and so it's sort of going crazy, or at least that's the way I like to think of it. And that's the key symptom for acute spinal cord compression. And then in the late stage, we might see autonomic dysfunction, so bowel, bladder incontinence, and retention. And then red flag symptoms are rapid neurological deterioration, and that's sort of indicating it's an emergency. But any sort of signs of acute spinal cord compression, you're wanting to do investigations as quick as possible so that you can sort of proceed with management as soon as you can. So how do we differentiate acute spinal cord compression from other conditions? So lumbago, we have sort of key features which will be localized back pain, and there won't be any neurological symptoms. Sciatica will be lower back pain which radiates to the legs due to nerve compression. Caudal equine syndrome, as we mentioned, will be sort of lower motor neuron signs, bowel bladder dysfunction, perianal numbness. But then acute spinal cord compression will be the upper motor neuron signs, sensory loss below the lesion, and also motor weakness. Okay, and how do we investigate? So again, we're dealing with the spine, so it's no surprise that we're doing an MRI of the whole spine. But importantly, this must be done within 24 hours if spinal cord compression is suspected. Then we also want to do blood tests to help rule out infection and malignancy. And then before surgery, we're wanting to do group save and coagulation screen. So management of acute spinal cord compression, so steroid to help reduce the inflammation, immediate neurosurgical referral, surgical decompression if the patient is fit for surgery. And then given the most common causes, malignant causes, we will also want to be thinking about radiotherapy and chemotherapy, and then any supportive care that we can offer. So pain relief, thromboprophylaxis, bladder and bowel management, etc. What is the prognosis of acute spinal cord compression? So the key, as with all spinal cases we discussed today, the key factor is that time to treatment and trying to get them in surgery for decompression as soon as possible. 90% of ambulatory patients do remain mobile post-treatment, which is a huge plus. But only 33% of these patients regain walking ability. And if it's malignant, it's unfortunately a very sort of poor prognostic factor, and the median survival here is only 6 months post-diagnosis. So it's a key one to look out for with back pain, is just to think about spinal cord compression and then metastatic spinal carcinomas. So key takeaways for both the spinal infections and acute spinal cord compression that we discussed are spinal infections are rare, but they're very serious, and so they need early diagnosis and prolonged treatment. So once you've ruled out sort of cauda equina, because that's what everyone thinks about, we then need to be thinking, okay, is there any infection going on here, and is there any compression? MRI is going to be the gold standard for both spinal infections and acute spinal cord compression. It is a neurosurgical emergency, so urgent steroids and surgical decompression needed, and the time to treatment is going to be the most critical factor in the acute spinal cord compression prognosis. Okay, finally, and we're a bit ahead of schedule here, but I'm sure people aren't too opposed to a whistle-stop tour of the spinal cord sort of conditions, but we'll want to look at spinal stenosis. So spinal stenosis is the narrowing of the actual spinal canal, so what we were sort of talking about earlier, and this does cause compression of the spinal cord or the nerve roots. Most commonly affects the lumbar and cervical spine, and lumbar spinal stenosis is the most common type. It is more common in patients who are older than 60, and as due to the degenerative changes that we see there. Okay, types of spinal stenosis. So there are 3 types of lumbar spinal stenosis. So central stenosis, which is of the narrowing of the actual central spinal canal. Lateral stenosis, which is the narrowing of the nerve root canals. And then foraminal stenosis, which is the narrowing of the intervertebral foramina. So again, this is another way to categorize which part of the spine is actually stenosed and what is being affected. The causes of spinal stenosis, so several conditions can contribute to spinal canal narrowing. So this can be congenital, and it can also be degenerative. So there might be facet joint arthritis, disc disease, bone spurs. Again, these are degenerative, which is why we see spinal stenosis in that older population. Herniated discs can also contribute to spinal stenosis. Thickening of the ligaments that attach the spine is also sort of a key cause of spinal stenosis, and narrowing of that space. Spinal fractures, vertebral slippage, and then also tumors. And again, all of those three just causing that space that the spinal cord is able to sort of sit in being compromised. So the symptoms, so unlike the other ones that we've seen, these are going to be more gradual onset. You know, a longer history of back pain and the other sort of symptoms that we'd expect to see here. And then the severity also depends on how compressed that spine is. Severe cases, importantly, can cause caudal syndrome. And so it's important to think about that when we're dealing with spinal stenosis or that sort of picture. But the key feature is that intermittent neurogenic claudication, which is also sort of known as pseudoclaudication. So that on and off features of back pain that we see. The regions, so going for Socrates, what are the sort of areas that we're sort of dealing with? It's the lower back, buttock, and leg pain. We're also going to see some leg weakness. Importantly, symptoms will improve with spinal flexion, so leaning forward. So it's a good test to sort of see that claudication in action. So if we're giving the spine more space, does that improve the symptoms? And then symptoms likewise will worsen when we're standing or walking, and that's due to that spine extension. And then importantly, lateral and foraminal stenosis can also cause sciatica. So it's an important link for all these conditions, how we can have infection leading to spinal cord compression. And then also in this case, we have sort of spinal stenosis, which can cause sort of caudal equina syndrome. So it's important as well here when we're dealing with claudication, how do we deal with or sort of differentiate between neurogenic and vascular claudication that may be occurring? So peripheral artery disease is an important differential. Importantly, this pain will probably be more localized sort of the calves and will be relieved with rest. When we're dealing with sort of neurogenic claudication, we're going to be more around the back, buttocks, and leg region rather than the calves themselves. And then the actual sitting and bending forward will help relieve the pain rather than just rest specifically. So the patient might say that they sort of have the symptoms when they're laying down rather than in peripheral artery disease, which is, again, due to that exertion, and that would lead you to a more vascular diagnosis. And the further tests we can do is sort of peripheral pulses. So this will be normal in neurogenic cases, will be reduced and absent in peripheral artery disease, and then ABPI, which will be normal, and then low in PAD. So tip, if the exam mentions normal peripheral pulse or ABPI, you can think of spinal stenosis rather than vascular disease. But equally, you might not have had spinal stenosis as a potential cause, and you're reading the question and it seems to be all linked to vascular cause. But if it sort of mentions this normal peripheral pulse or ABPI, but they're getting that claudication of pain, spinal stenosis can sort of be something you think about. And then investigations, again, MRI of spine, that can't be surprising at this stage. And then the other ones are just to exclude other things we might be dealing with. So essentially just excluding peripheral artery disease. The management, again, this will be guided by spinal specialists. There's several options for this. So conservative options, which will be exercise and weight loss. And again, that depends on the condition that we're dealing with. Pain relief and physiotherapy. So as well, to add to this, I think things like Pilates and things like that are often recommended by spinal surgeons before taking the step to go to surgery. But there are surgery options if possible. So we can have a laminectomy, which is removal of parts or all of the lamina to decompress the nerves. But importantly, this has sort of variable results. So it's not always going to be effective. Or the other option we have is epidural steroid injections. So there's limited evidence on the success of this. So they're not routinely recommended, but potentially something that you might see done in certain clinical settings. Perfect. So that concludes our quite rapid exploration of the spine and the key conditions there. And hopefully, if you weren't too sure on the red flags or how to take a spinal history, asking some of those key questions that cover those red flags. So, the saddle anesthesia or the bladder bowel problems, the bilateral pain, any fevers, and then also sort of claudication, uppermost neuron signs, things like that, just sort of allowing you to piece together the things that you'd need for a succinct history for a back pain patient. Yeah, perfect. I'll hand back over to Gabrielle.
So thank you so much for an amazing session. Shall we go through the polls?
Yep, sounds good.
So I'll release the first poll now, and if you want to like read out the question and some of the options while people are deciding.
Perfect.
So it should be live.
Yep. So what is the most common cause of choroid equina syndrome? So trauma, neoplasm, infection, disc herniation. So again, we didn't actually cover directly which of these would be most popular. So it's a good thing to think about. Which of these would you guess to be the most common cause?
And guys, please just, if you don't know, just guess, just give it a go. Honestly, there aren't that many people on this session, so there's no reason to feel embarrassed or anything if you get it wrong. It's
Perfect.
all about learning. It's a safe space for learning.
Exactly, yeah. So I'm seeing two answers there. So infection and disc herniation. So again, yeah, really good ideas. And especially given we covered infection, I can see why you'd go for that. It is actually disc herniation. And I think that's again because when we have an infective picture, there's quite a high risk of stenosis. But for choroid equina specifically, I think that disc herniation in those regions, the L4, L5, that's sort of the key leading cause for that one. So well done if you answered disc herniation.
Okay, I'll release the next poll as well, which is now live.
So yeah, this one is, which of the following is not a clinical feature of choroid equina syndrome? So one of those awful, which of these is not MCQ styles? But it's important to recognize this one in particular, given the other differential that you might expect.
Again, please don't be scared to answer at all.
Perfect. So we've got two responses there. So we got 4 on the last one. Any chance we could get up to 4? No worries if not. So yeah, the correct answer for this one is upper motor neuron signs. So if we remember, upper motor neuron signs are sort of more linked to our acute spinal cord compression. And so that would be for that differential. So yeah, 100% on that one, which is good.
And the last question.
So we covered this one quite a lot today, but what is the gold standard investigation for diagnosing choroid equina syndrome? So hopefully people can have a go at this one. Perfect. So we've got 3 responses. So yeah, in this case, MRI is going to be the first line investigation. So 100% on that as well, which is good. So well done for everyone answering that.
Okay, amazing. So that is the end of that. I'm just going to release this now. So thank you so much, Thomas, for such an amazing session. That was really informative. The feedback form is now available in the chat. Please, can you guys complete it? I'm sure when you are further along, you'll need feedback from teaching as well at some point. So please help Thomas out and help us out. So we would be so grateful if you could complete that. Yeah, so don't forget to fill it out to receive your certificates. Also, you get discount codes for Teach Me Surgery and pass their MRCS. Also, be sure to complete the Google form for a chance to win 3 access to the Geeky Medics surgical flashcards and their OSCE stations. The link for this is also available in the chat. Our next session is going to be next week on Monday, and we will be covering C-sections. So please be sure to check that out. We'd love for you to join us again. Make sure you follow us on our social media platforms, and the links are available for those in the chat as well. You'll be able to receive updates on the upcoming sessions via these platforms. We'll also be posting SBAs on our socials for additional practice, so keep an eye out for those. Don't forget to visit our website, where you'll find a resource bank with materials, not just for this session, but all of our other sessions in this teaching series. These resources include summaries and a question bank featuring extra questions that aren't available on our social media. So to access them, please create a free account on our learning portal. We hope you found today's session valuable and engaging, and thank you once again for joining us, and we look forward to seeing you at our next session. Again, if you have any questions, please put them in the chat. Please, I would be so grateful if you could complete that feedback. Let me know if you're having any issues with the form. Let me send the feedback form as well. I've emailed it to everyone, but you can also click on the chat as well, and the feedback form is in there. So yeah, if you don't have time at the moment, you've got it in an email as well. So if you just have time, procrastinating at some point, please complete that. Are there any questions before we go? Okay. I don't think there are any questions for you, Thomas, so you must have done a really good job. Okay. So I can see we've had 2 responses, which was great. I'm just going to Okay, I have also shared again the feedback with the attendees, so please complete that when you've got a chance. If there are no questions, I think we're going to end it there. Thank you so much for joining us, and thank you again, Thomas, for leading a really amazing session.
Yeah,
Okay,
perfect.
bye.
Thank you so much.
Bye, everyone. Bye.